Hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, is an immune-mediated disease. It results from inhaled antigens affecting the alveoli and small airways. Sensitization through IgG antibodies is a necessary step for disease development. However, these antibodies alone are not sufficient to cause clinical symptoms. High-risk groups include farmers, bird owners, and industrial workers. Interestingly, smoking is considered paradoxically protective in this condition. Common antigens include thermophilic actinomycetes from moldy hay and avian proteins from feathers. Chemical triggers like isocyanates in polyurethane are also frequent offenders. The pathophysiology involves dysregulated Th1 and Th17 immune responses. Chronic HP leads to irreversible fibrocyte-mediated lung fibrosis. Current guidelines classify the disease into non-fibrotic and fibrotic phenotypes. This system replaces the traditional acute, subacute, and chronic categories. Acute HP presents with fever, chills, and cough 4 to 8 hours post-exposure. These symptoms are reversible if the offending antigen is strictly avoided. Fibrotic HP shows insidious progression of dyspnea, fatigue, and weight loss. Digital clubbing may be present on physical examination. High-resolution CT imaging reveals ground glass opacities and centrilobular nodules. Air trapping is a key diagnostic feature often seen on expiratory scans. Fibrosis in HP often displays subpleural honeycombing that spares the lung bases. This distribution pattern helps differentiate it from idiopathic pulmonary fibrosis. Bronchoalveolar lavage typically shows a marked lymphocytosis. The CD4 to CD8 ratio is frequently less than 1. Histopathology reveals loose non-casating granulomas and lymphoplasmacytic infiltrates. These findings are diagnostic cornerstones in complicated cases. The primary treatment for all forms is total antigen avoidance. For symptomatic patients, initiate prednisone at 0.5 to 1 mg per kilogram per day. Do not exceed a total daily dose of 60 mg for the first 1 to 2 weeks. Gradually taper the corticosteroid dose over the subsequent 2 to 6 weeks. In cases of progressive lung fibrosis, consider antifibrotic agents like nintedanib or pirfenidone. Advanced fibrotic disease may eventually require lung transplantation.